I bet I can't record. Okay, hold on. Let me see. Okay, we are recording. All right, so we're going to continue with lecture 27. We had been talking about hemolytic disease of the newborn. And you guys remember there's two types of hemolytic disease of the newborn. It could be due to ABO incompatibility. So if mom is type O, remember she does produce anti-A, B, which is of IgG classification and can cross the placenta. So that is what causes ABO hemolytic disease of the newborn. So mom is O and the baby could be either A or B. All right, so we have that incompatibility through the ABO there. The other type is still an IgG antibody, but non-ABO. This would be the number one instance that we see this would be because of anti-D. Other instances could be any other clinically significant IgG antibody. Little c is very common, followed by KEL. So D, little c, and KEL are the most common ones that can cause the most severe cases of hemolytic disease of the newborn. But others are capable as well, Duffy A, Duffy B, JKA, JKB. All of those clinically significant ones are capable of causing hemolytic disease of the newborn. So if mom has that antibody, oftentimes, once it's identified, she is considered a high-risk pregnancy, because if baby is antigen positive, then mom's antibody could attack baby red cells. And that would be what would cause baby's anemia, what would cause, after birth, it could cause increased bilirubin. And remember, that's the risk for babies after birth. The mom's liver is no longer available to conjugate that bilirubin. And if it were to travel to the brain, it can cause kernicterus, which could be fatal for the baby. So this is why hemolytic disease of the newborn is so important that we diagnose and monitor. All right, so let me get to the slide that we were on. So in the event that the baby is in fetal distress, symptoms of anemia, we can do a intrauterine transfusion, and there are specific transfusion requirements. So we need to make sure our products are safe for the baby. One of those things is we always want to try, and depending on, I have a disclaimer here, depending on what your SOP at your institution says, if mom and baby are both the same type and you're dealing with a non-ABO antibody, some institutions might have in their SOP that they can give type specific. However, it is a good rule of thumb to always give when you're doing a, especially if you're doing an intrauterine transfusion, you always want to give O negative, all right? So that's just a standard rule. However, like I mentioned, you can give type compatible with mom and baby, but most places will just give straight O negative, all right? That's the safest for the baby. And then again, if mom does have that circulating antibody, we definitely want to make sure that the blood that we are transfusing during the intrauterine transfusion is antigen negative. So for instance, if mom had anti-Duffy A, that unit that we are transfusing into the baby would need to be Duffy A negative. And usually we do cross-match compatible with mom's plasma. All right, because remember, these babies are not going to build antibodies until 6 months of age. So whatever antibody is coating baby cells or in baby circulation came from mom. So we can do cross matches on mom's plasma. If it's compatible with mom, it will be compatible with baby. And then some other requirements or attributes of those products. We need CMV negative. This has been replaced. Remember, we talked about leukodepletion is taking the place of the requirement for CMV negative. So you could read that as CMV negative or leukodepleted. Fresh, remember, for neonatal transfusions, we want it to be between 5 to 7 days old. If you don't have fresh O negative red cells available, you could wash. And the reason for washing is, you remember, as these cells are in storage, the longer they sit in storage, the more potassium is going to be released. And it's that potassium that could be fatal for the newborn. So if we wash it, we can remove all of that excess potassium and anything else as well. And remember, your anticoagulants also plays a role here. We do not want to use Adsol as our anticoagulant. So if your unit of red cells has Adsol, that is not suitable for a neonatal transfusion. One way around that, if that's the only additive that your institution has, you could wash it. You could wash that Adsol away, and then you would just have fresh red cells. And then because our neonates are considered immunocompromised, they're in that population, we need to prevent graft versus host in these patients. So the blood will also need to be irradiated. And then, like I mentioned, we can cross-match that unit to make sure it's compatible with mom's plasma. If you're at an institution where you have a neonatal intensive care unit and the baby has been transferred to you, you will not have access to mom's plasma, of course. So in those instances, if a DAT was performed and then you followed up with the Eluate, you could cross-match using that Eluate because the Eluate is going to have the antibody in it. Or you could, if you have a peripheral blood on the baby, you could cross-match with baby's plasma because baby's plasma will have mom's antibody in it as well. All right, so it depends on how your institution is set up. If you have mom, we can use mom's sample. If you only have the baby where the mom did not birth at your institution, you will not have a sample on mom. So then we can use the Eluate for our cross-matching or baby's serum or plasma, okay? And then part of that newborn workup, and don't be surprised, I was kind of surprised when I first started working in blood bank many years ago. When we did our newborn workups, we only did a cord blood workup if mom was type O because of the risk of ABO, hemolytic disease of the newborn, or if mom was Rh negative, unless mom had, of course, another known antibody. So, but for moms that are type A or B, the risk for ABO, hemolytic disease of the newborn, does not exist because they typically do not have that IgG form of A, B that can cross the placenta. So it's really, ABO is only a concern if mom is type O. And we have some examples at the end of this lecture that we will go through. All right, so on your newborn workup, you can do it on the cord blood, or if the cord blood is not available, if that baby was not born at your institution, you won't have the cord blood, you can use a peripheral blood sample. All right, you guys might have heard of this before. The cord blood actually contains what we call Wharton's jelly. The Wharton's jelly is kind of like the support material within the cord blood. And in this example, in the image here, the cord blood or the Wharton's jelly is kind of around the vessels. So you have the vessels that provide blood to the baby and then the blood coming from baby back to mom. And so the Wharton's jelly is in between all of these venous pathways. So when they collect a cord blood, you're getting blood and it will have that Wharton's jelly, and it's a very gelatinous. If you guys have never seen a cord blood before washing that cord blood, it looks like grape jelly. If you think about, that's the substance of it. And so think about that if that can cause some false positives, all right? So if you don't adequately wash your cord blood, that Wharton's jelly could look like agglutination in our testing. So oftentimes cord bloods will have additional washing requirements. Usually a good rule of thumb is 4 to 8 times to wash that cord blood before you do any testing. And remember, when you're dealing with cord blood, those are only cells. So, and on babies anyway, we only do the forward typing. Okay, so we're only doing our ABO RH. That ABO does not contain your reverse typing, the A cells and B cells, again, because these babies have not built those antibodies. So your back type is going to be negative. And so when you receive that cord blood or your peripheral blood, after washing that cord blood a series of 4 to 8 times, we'll do our ABO, like I mentioned, forward typing only. We will do our RH to include week D testing. All right, so remember, moms and babies are in that population where if they're negative at initial spin, we want to make sure that we do week D on them. And week D is very important in moms. We'll talk about it in the next lecture. Does she get ROGAM or not? Okay. And then the DAT, right? So anytime you're dealing with a newborn, that DAT is the indicator if hemolytic disease of the newborn is present. If your baby DAT is positive, that means something is coating baby cells. Mom's antibody is coating baby cells. It's our job in the blood bank to find out what is coating baby cells. Is it due to ABO or is it due to another circulating IgG antibody? And one thing you have to be really careful when you're working with newborns, especially if they have been a high-risk pregnancy. We have the potential, if they're a high-risk pregnancy, that once they're born, they could have had an intrauterine transfusion. And in the event that the baby had an intrauterine transfusion, let's say the baby's really type A, but according to our protocol, we give the baby cells type O. So when we do our ABO typing, if they have had an intrauterine transfusion, those donor O cells are going to dilute out the baby A cells. Okay, so whenever we do a newborn workup, we always have to be really careful. We don't want to mistype the baby as an O when in reality they're type A. So we always look for that mixed field agglutination present following an intrauterine transfusion. And then you would want to do your DAT just like we always do, macroscopically, look for agglutination with your eye. If you don't see any, look for it under the microscope. And then, just like always, if your DAT is positive, we must perform an eluate. Right, and so you guys, we talked a little bit about eluates, but now we're really going to talk about the different types of eluates. So if your baby has a positive DAT, we want to do an eluate. And what this eluate is going to do, if the DAT is positive, that indicates that some type of antibody is coating baby cells, okay? By performing an eluate, we can pull off that antibody. That antibody will be in the eluate, so that will be in the supernatant. And we can run that eluate with some known cells to identify what is causing that, the positive DAT, what's coating baby cells. So typically, if we suspect that the baby has hemolytic disease of the newborn due to ABO, the type of eluate that we will do is called a Louis freeze. And the way this works, it's in the name. So you're going to take an aliquot of cells, you're going to wash them. Very important, very important. During that last wash, that you save that last wash. So after you're doing your washing, just like you were making your cell suspension, except you're doing it 6 to 8 times, all right? You're going to save that last wash. You're not going to decan it like we normally would, all right? You're going to save that last wash. That last wash must be run in conjunction with the eluate, and that last wash must be negative, okay? That just, it's kind of like an internal quality control that the antibody has adequately been washed away. So there's no unbound antibody remaining in our last wash. Okay, so I have an example coming up that will be more clear. All right, so after your last wash, you pull off that saline. You're left with probably about 1 ml or 2 of cells. All right, this performing eluates does take a lot of red cells. So you're left with cells. You're going to add just a few drops of saline to your red cell button. Okay, and then you're going to take, you're in like a 13 by 100 tube. You're going to take that tube. And I always kind of tilt it to the side, and I like the cell suspension to kind of coat the edges of the tube. Then you're going to put it in the freezer, and it can be a regular freezer anywhere from -6 to -70. The average temperature, usually in blood bank, we have a -18 freezer that we put it in for 10 minutes. All right, and you guys probably know what happens when you freeze cells, and then after that 10 minutes, you're going to run it under some lukewarm water. All right, what that's going to do is those cells have been rapidly frozen, and now you're rapidly thawing them out. That will lyse the cells. All right, so the antibody that was attached to the cells is now unbound in our suspension. And so what you're going to do is you're going to centrifuge that down, a very hard centrifuge, for 2 minutes. And the supernatant, so you'll have your cells that you'll hardly have any cell button because most of the cells are lysed. But you might have a few cells remaining. But that supernatant, all right, the cells have lysed. The little bit of saline that we had added now contains all of the antibody. All right, the cells are lysed, the antibody has been released. It is in that eluate. So your supernatant is the eluate. All right. And then in Eluate freeze, we are going to run that eluate using A negative cells, B negative cells, O negative cells, and O positive cells. Now, you might ask yourself, why do we need to run A negative cells and B negative cells? If we suspect ABO hemolytic disease of the newborn, mom's anti-A, anti-B will attach to our reagent A cells and B cells, and we can identify exactly what is coding mom's cells. Okay, so if it's anti-A, it will attach to the A cells. If it's anti-B, it will attach to the B cells. And if it's anti-A comma B, it will react with both the A cells and the B cells. And that is how we can identify your ABO hemolytic disease of the newborn. And then we just add O negative cells and O positive cells. If it's another IgG antibody, then it would react with your O negative cells and or your O positive cells. Let's say there's also anti-D involved. Anti-D would react with your O positive cells, right? Because it's going to bind to the D antigen on these reagent O positive cells, okay? And so here's some examples of expected eluate reactions, okay? So we've done the DAT on the baby. It was positive. We performed the Eluate freeze eluate. We ran it with our panel of cells, including A negative, B negative, O negative, and O positive, okay? So if you get a positive reaction with the A cells, then it is hemolytic disease of the newborn due to mom's anti-A coding baby A cells. Okay, does that make sense? Yeah. Whereas if we did the eluate and it was positive with A and B cells, then it would be A comma B coding baby cells. Okay. And we have some examples that we're going to go through at the end of this lecture, so you guys will be able to see that. And so here's what your anti-B would look like. And I know this is confusing because we talked about anti-A and anti-B being of IgM, unable to cross the placenta. There are very small amounts of IgG anti-A and anti-B, okay? So if you have positive reactions due to ABO hemolytic disease of the newborn, that is why our DAT tends to be very weak when it's related to ABO, okay? And at the end of this lecture, I believe, we have a comparison between ABO hemolytic disease of the newborn and hemolytic disease of the newborn due to another IgG antibody. Your DAT is very much stronger when it's another true IgG antibody, okay? Notice because we're only dealing with the ABO antibodies in this situation, in this scenario on the screen, it's anti-B. Notice that we have negative reactions with O negative cells and O positive cells. That just indicates that there is no other IgG antibody reacting with our reagent cells, okay? And then here is an example of where it would be anti-A comma B. And notice our O cells are still negative. So there's no other circulating IgG antibody. All right, here's an example. Notice after our DAT performing the Eluate freeze, we've performed our A cells, our B cells, our O negative cells, and O positive cells. Notice how we have all negative reactions with our A and B cells, negative reactions with our O negative cells, but a positive reaction with the O positive cells. That just indicates that the antibody we eluted off, baby cells, were reacting with the O positive cells. And because these cells are O positive, they have the D antigen. So we could, this would have to be followed up for confirmation, of course, need to run some more cells. But it is the anti-D reacting with these O positive cells, okay? Because these O positive cells have the D antigen, and then mom's anti-D, which was on baby cells, remember, because we're dealing with the eluate here, is reacting with the D antigen of our reagent cells. All right, does that make sense to everybody?
So it's because mom's negative blood during delivery crossed over, like the RH crossed over and attached.
So mom is RH negative in this case. All right, so she has anti-D in her circulation. Baby is RH positive, and mom's anti-D had attached to baby cells. We have eluted off that anti-D from baby cells, and now it is reacting with our O positive or D positive reagent cells.
Okay.
Yeah. You really have to talk through when you're trying to interpret these eluate reactions. You have to think about what you're testing and understand that you initially started with baby cells. Okay, so you have to ask yourself, am I dealing with mom or am I dealing with baby? And I think that helps a lot of students once they understand that they're testing baby cells on this eluate. And it's mom's antibody coding baby cells.
And if it wasn't mom, if it wasn't RH, then it would be either another IgG antibody.
Yep.
Or if it were A or B or both, it would be the ABO HDN.
Yeah. So if it was another IgG antibody, it might have reacted with your O negative cells. But anti-D will not react with your O negative cells, of course, because the D antigen is not there. Let's see if I can't remember if I have that example. I don't. So if you had a reaction with your O negative cells, then we would suspect that it's probably not D. It's probably another IgG antibody. And then speaking of the presence of another IgG antibody, so that's one type of elution. That's your Eluate freeze, commonly performed if you expect ABO, all right? There's another elution that is performed if you expect another IgG antibody other than ABO, and it's just an acid elution. Digitonin is the acid that's used. And so if you're in BloodBank, the commercial manufacturer might call it a digitonin kit. It comes as a kit, or it might be ether. But this is just an acid treatment. Again, acid treatment adjusts the pH, so it will dissociate the antibody from the red cells. And then it still can cause lysis of the red cells. So this is still a lysis eluate. And again, you go through a series of washing. You're going to add it's an acidic solution. Go through a series of washing. You save your last wash. Okay, still you save your last wash in the acid too, and then you'll run the eluate with like a panel to identify that IgG antibody. And note here on the screen it says when hemolytic disease of the newborn is suspected but not due to ABO. So this would be the preferred eluate method for other IgG antibodies. And a good rule of thumb when the acid elution is warranted, mom's IAT is going to be positive. Okay, so mom has the antibody circulating in her plasma. Baby is antigen positive, and during the fetal maternal exchange, mom's antibody is coding baby cells. And that's what's causing the positive DAT. There's a phenomenon that you guys need to be aware of, and it's called the blocked D phenomenon. So what happens is, and remember we have mentioned how serious anti-D can cause hemolytic disease of the newborn, can cause the baby to be anemic, can cause increased bilirubin, can cause kernicterus. If it goes untreated, that could lead to fetal demise. And usually in those cases where fetal demise occurs, it's because mom's anti-D titer is so high. And so when mom's anti-D titer is so high, it is pretty much coating every D antigen site on baby cells, okay? And so in our testing, think about this. If we are doing D testing on the baby and mom's antibody has coated all the available D antigen sites on those cells, our anti-D reagent has nothing to bind to because the anti-D binding sites are already taken up. So it is, it could look like it's a block D phenomenon. And I have an example. Let's look at an example. Coming up at the end of this lecture, there's an example. All right, so let's talk a little bit about exchange transfusions. In the event that you do have a severe hemolytic disease of the newborn, they might actually do an exchange transfusion where they're going to pull off a predetermined amount of red cells dependent upon the baby's weight, and then they will replace it with donor cells. So this is, in severe cases, usually it's determined on the amount of bilirubin. So if there is a high amount of bilirubin, and it's usually greater than 20 milligrams a deciliter, that indicates that that's a very high level with the potential for that bilirubin to cross the brain barrier and could cause kernicterus. Okay, so that's the concern here. We want to get rid of all of that extra bilirubin so we can do an exchange transfusion. And again, like I mentioned, it's going to correct that anemia. So we pull off red cells from the baby and then replace with donor cells the exact same amount. So we're not adding any extra volume into that baby's circulatory system. Another thing that it does, all right, so it lowers the amount of bilirubin, preventing kernicterus. It also, think about what's going on there. What's causing this hemolytic disease of the newborn is mom's antibody coating baby cells. So by doing this exchange transfusion, we also are pulling off those antibody-coated cells, giving the baby fresh donor cells, improving the lifespan of those red cells, all right? So thereby, kind of correcting the baby's anemia. And so usually when they do a transfusion exchange, they want to use whole blood. And so you guys know most blood banks don't keep units of whole blood. We've talked about that. So what we do for exchange transfusion is blood bank will make their own whole blood. So what they usually do is they will take a pre-designated amount of red cells and mix it with AB FFP. And so that's usually what they do. And so that the addition of FFP just makes sure that the albumin and the coagulation factors are established in the baby as well. And it's a good rule of thumb. Remember, for neonatals, we usually try to give O negative. If you know mom and baby are the same type, some places might even give type specific, but that has to be in your SOP in order to do that. A good rule of thumb, and for your board of certification, I would always go with O negative red cells, AB plasma. And then again, those red cells must be antigen negative. We want to use fresh blood. that is CMV negative or leukodepleted. And then again, make sure we can cross-match to ensure that it's compatible by using mom's plasma or baby's plasma or the Eluate. So I took this chart from your textbook. It just kind of explains selection of blood products. Again, group O, Rh negative, or you could potentially use whatever ABO compatible with mom and baby. Red cells that are fresh, between 5 to 7 days old. And then again, we'll resuspend in AB FFP. And then antigen negative and cross-match compatible with mom's plasma or baby's plasma or the Eluate. And then again, the amount of blood that's pulled off is determined by the baby's weight usually. It might be 5 mils, it might be 25 mils. And then BloodBank always allows for a little bit of extra in there just for them to have during the process so they can make sure there's no air bubble or anything present like that. It's very important before you transfuse a baby that ABO-RH has to be done, and again, only the forward type, and we want to make sure an IAT, if you have mom, an IAT on mom has been done, and then the antibody has been identified for mom as well. If you're at an institution where you don't have mom, you can call the transferring hospital, the one where the baby was born and then they transferred it to you. You can call them and ask what mom's antibody was. However, that gives you a history. You still have to perform testing on your baby. You have to prove that that antibody is in baby circulation. And then just like our exchange transfusion, the requirements for neonatal transfusions, all the same. Must be fresh, hemoglobin S negative, CMV negative or leukodepleted, irradiated, CPDA additive instead of Adsol. And then if you don't have Adsol or you don't have fresh blood, you could wash. So that's a really good Board of Certification exam question. They like to ask, what are the requirements for neonatal transfusions? So you guys need to know these requirements. All right, so the remaining slides of this presentation have some mom and baby scenarios that we can look at. And I want you guys to, when you're approaching these scenarios, I want you guys to look at a few things when you're addressing these. Number one, always look at mom's type. Remember, if mom is type O, there is the potential for there to be hemolytic disease of the newborn due to ABO incompatibility. All right. Number two, if mom is Rh negative, does she have anti-D? Okay, and that will let us know if hemolytic disease of the newborn is due to anti-D, or if she's type O or any other type and her IAT is positive, then that means mom has a circulating antibody. What is the antibody? Is it able to cross the placenta, and is it causing hemolytic disease of the newborn? All right. And then you always want to look at baby's DAT. All right. So hemolytic disease of the newborn is only present when your DAT is positive. So if baby's DAT is positive, then we have to figure out why is that DAT positive and what is causing, what is coating baby cells, causing cell destruction, causing the anemia present in the baby. Okay. So let's go through these examples. Here we have a mom who is O negative, weak D negative, and IAT is negative. So her IAT is negative, so we don't expect any unexpected circulating IgG antibodies. However, she is type O, all right? So then we give the baby sample. The baby sample, oh no, baby's type A, all right? Mom is type O, baby's type A. So we do have ABO incompatibility there, okay? And then look at your DAT result. Remember I said that with ABO, hemolytic disease of the newborn, your DAT is very, very weak. Okay, and so we have a weak reaction here with our DAT. Anytime your DAT is positive, you have to do an eluate. So we take baby cells, we do we expect a ABO, hemolytic disease of the newborn here, but we want to confirm that. So we will do a Louis freeze elution. And notice when we perform our eluate and then we run that eluate against the A negative cells, B negative cells, the O negative cells, the O positive cells, we have a 2+ reaction with the A cells. So this is an example of hemolytic disease of the newborn because the DAT is positive caused by mom's anti-A coding baby A positive cells. So your interpretation is hemolytic disease of the newborn due to ABO, specifically anti-A. All right, so here's another example. Mom is type O negative. All right, so she's type O. She has the potential for ABO incompatibility. She's Rh negative. And then we do her IAT and anti-Lewis A was identified in her IAT. And if you look at baby testing, we do have a weak positive DAT. Do you think this weakly positive DAT is due to anti-Lewis A? What do we know about Lewis A? Remember, Lewis A cannot cross the placenta. All right, so it is not capable of causing hemolytic disease of the newborn. So typically, when Lewis A is identified in pregnant females, we know that it is unable to cross the placenta. So it is not what is causing this positive DAT in the baby. All right, but take a look. Mom is type O, baby is type A. So we could potentially have a ABO hemolytic disease of the newborn. Right, so we perform our eluate, we do the Louis freeze, and then when we look at our eluate results, notice that we have a 2+ reaction with anti-A and a 1+ reaction with, 2+ reaction with A cells, 1+ reaction with B cells. So this is ABO hemolytic disease of the newborn due to anti-A, B. So remember, mom's anti-A, B, which is IgG, is able to cross the placenta attaching to the cells. All right, in our next example, we have an A negative mother. Do we suspect hemolytic disease of the newborn due to ABO in this mom? Because she's not type O, we do not expect ABO hemolytic disease of the newborn. And her weak D is also negative. But look, her IAT is positive. And through the antibody identification, we identified anti-D. Anytime you identify an antibody in mom, we have to titer it. And so her titer was 64. All right. And in the next lecture, we're going to talk about the presence of anti-D in a mom and whether or not to give RhoGAM. If you have a titer that is higher than 1 to 8, it is really considered true anti-D, and it is considered clinically significant in mom. And we'll talk about that in the next lecture. So mom has an anti-D titer of 1 to 64. All right, baby is O positive. So I want you guys to think about this. Mom is A negative with anti-D in her circulation. Baby is O positive. What is happening with mom's anti-D? Mom's anti-D is coding baby's D positive cells. All right, that's what's happening in this scenario. And then take a look at our DAT. The DAT is positive, so we know there's hemolytic disease of the newborn, and it's actually quite a bit stronger than our previous examples. It's a 2+. All right, and that's because we're dealing with a non-ABO antibody, right? You'll have a stronger DAT when a IgG antibody is suspected, right? So we did an acid elution, right? Because we expect an IgG antibody. Acid elution is the preferred elution method if you expect a non-ABO antibody. And notice that we have a 2+ reaction with our O positive cells. So that lets us know mom's anti-D was eluted off baby cells, causing their reactions with our O positive cells. Okay. So interpret this: hemolytic disease of the newborn due to an IgG antibody, which is anti-D. All right. Remember that blocked D phenomenon that we talked about? Keep that in the back of your mind. Usually you'll only see that if mom's anti-D titer is significantly high. And so in the next example, we're going to look at this. All right, so here we go. Mom's type is A negative. All right, so because mom is A, we don't have to worry about hemolytic disease of the newborn due to ABO. Weak D negative, her IAT is positive. Look at her titer. Her titer is 256. That is super high, and especially in a pregnant female. So what's happening here is baby is probably Rh positive, and mom is being exposed to those Rh positive cells. She is actively building anti-D, all right? So her anti-D is continuously building, and that's why her titer is so high. All right, and if you look at baby, remember I mentioned the block D phenomenon? So what happens is when mom's titer of anti-D is so high, it will take up all of the positive binding sites on the baby cells. So our baby could potentially falsely type as Rh negative, all right, because our antisera will not be able to bind to any of the D sites because it's already has the antibody attached, right? So that anti-D kind of masks all of the D antigen sites on baby cells. In this example, because mom's titer is so high and the baby's DAT is positive, we are actually getting a weak D positive control. So, and that is another example that lets you know that antibody is coating baby cells at a very high rate, right? So this would be an example of where this baby is in severe respiratory distress, okay? For these babies, this baby probably needs an intrauterine transfusion. This would be a severe case, all right? So our DAT is 2+. We do our acid elution, and we have a 2+ reaction with our O positive cells. And so we can concur that it is mom's anti-D reacting with these O positive cells extracted from baby cells. And then the reason for the ORH invalid is because mom's anti-D is coating every antigen site on the baby cells, okay? And so this is the blocked D phenomenon. You have to keep that in mind when mom's D titer is so high. In a normal situation, mom's anti-D titer will not be that high. This mom probably has not received any prenatal care, all right? This is when you'll see this situation. Mom's anti-D titer is so high, it is masking all of the D positive antigen sites on baby cells. Normally, if mom has anti-D and it's at a lower titer, there's still some D antigen sites available on baby cells that we can detect to prevent this block D phenomenon. All right, does that make sense to everybody? That's kind of a situation. It's rare. There's not too many documented cases of block D phenomenon, but it can happen when the D titer is so high. And then there's a note here, it says, and just like with any patient, whoops, I didn't mean to do that. With any patient, if you have a positive weak D control, you have to figure out why that D control is positive. So we've already done our DAT. We know why our baby's RH control is positive. We could do another type of elution. It's called the glycine EDTA. It's a treatment of the baby cells. However, it does not lyse the cells. So what we are wanting to do is pull off the antibody from the cells so we can test the cells. all right, because it's that antibody coating the cells, preventing us from detecting the D antigen on the baby cells. The glycine EDTA treatment preserves the cells, all right? So it pulls off that antibody. It doesn't lyse the cells are still viable. Now the DAT is going to be negative because the antibody has been detached, and we can obtain a true D interpretation.
So then would you just repeat the D testing portion only?
Yep. So what you would do is after you perform your glycine EDTA treatment, you have your cells, you would make your cell suspension, repeat the DAT to confirm that it is negative. And then if your DAT is negative, then you could repeat your D tube and your control. You could repeat that. All right, so that concludes lecture 27. So you guys, in summary, remember that anytime mom has a circulating IgG in her plasma, and it is considered clinically significant, meaning that it can cross the placenta, it can cause hemolytic disease of the newborn. And the concern there is that the baby will have symptoms of anemia. After birth, the mom's liver is no longer available to conjugate the bilirubin. So the baby could have increased bilirubin, and in severe cases, if it is high enough to pass the blood-brain barrier, it can cause kernicterus. That is when an exchange transfusion is warranted. In newborns, hemolytic disease is oftentimes due to ABO. In ABO, the hemolytic disease of the newborn symptoms are not as severe. Oftentimes you hear of babies having to be put in the natural sunlight. They're sent home. That's just because the symptoms are mild, and cells will be easily cleared without further treatment. However, if it's due to anti-D or another IgG antibody that is clinically significant, those often will warrant, maybe the babies have to be under a UV light at the hospital, or exchange transfusions are warranted, all right, depending on the severity of the hemolytic disease of the newborn. And we talked about two different types of eluates. Remember, if ABO, hemolytic disease of the newborn, is suspected, a Louis-Freeze eluate is preferred. If another antibody other than ABO is present, such as D, E, Cal, Duffy A, Duffy B, then the acid elution is preferred. And so we went through some case scenarios of hemolytic disease of the newborn. You guys review those. Make sure you feel comfortable with that. I gave you some hints on approaching those. Make sure you look at mom's type. Is she type O? Then it could be potentially an ABO hemolytic disease of the newborn. Is her IAT positive? That means she has another circulating IgG antibody. And then always look at baby's DAT. If that baby's DAT is positive, then hemolytic disease of the newborn is present, and we have to figure out what type of hemolytic disease of the newborn, okay? You guys have any questions? All right. We'll have some more hemolytic disease of the newborn situations and ROGAM scenarios in the next lecture.